This is a mobile structure which you see over there, and it has its own clinical implications whenever the thrombus that also you need to keep in mind in some unusual presentations. Eustachian valve, so whenever you have a Eustachian valve which is fenestrated, it is a variant of the Eustachian valve. So this would be the Chiari network, so it is almost like a membrane with multiple holes inside it, and this has got the same implications as the Eustachian. You see that it's close relationship with the SVC, the prominent area where sort of hook-like, beak-like, it is associated close to the RA appendage. Then you have the pectinate muscles. So this is more seen when you're doing transesophageal echoes, and how pectinate muscles look like. So you have these series of muscular ridges as it goes deeper and deeper into the appendage. So it can be the right atrial appendage. It can also be seen in the left atrial appendage. And transthoracic, you may not see it so well. You may not see it at all in most of the cases, but you do see this quite often in the transesophageal echo. Then you have the coronary sinus also. Once in a while you will see a valve which is very, it is associated with the coronary sinus. So this can be the basin valve. So be aware of the basin valve which is associated with the coronary sinus. Now, coronary sinus per se is not a normal variant, but it just included just to sort of, sometimes it can be mistaken for those who are not so familiar with echo or who are starting newly. It can come as a dark sort of an appearance and interrupting the intraatrial septum, and then you can mistake it for ASD. So whenever you see something like this, think of the possibility that could it be coronary sinus without jumping into a conclusion of it's an ASD. So the sort of expose this right ventricular apex, and you'll see a lot of these tuberculations. So again, just keep in consideration that is it just a normal sort of appearance of the right ventricle, or could it be something else? That is one. And then the moderator band also, you have to see that it comes from the base of the anterior papillary muscle and it comes all the way down to the septum. So this is again a characteristic feature whenever you're trying to find out whether it's RV or LV, especially congenital heart disease. This is an important landmark, anatomical landmark. And then again the tuberculations, as I was saying, so you have these tuberculations, it can be mistaken for thrombi, especially when you have a setting where thrombi is likely to occur. So this can cause a lot of sort of indecisiveness. So remember that the RV is heavily tuberculated, and whether are you looking at a tuberculation or is it a clot. Then you have, once in a while you'll see the tricuspid annulus, which can be very thick and very shiny. So this again can be mistaken for a thrombus or a tumor. So this is lipomatous hypertrophy. It has its own clinical implications in a very limited sort of way. But when you see something which is very thick and very bright and which is at the annulus level, it can be on the septal side also. So it could be lipomatous hypertrophy. Then of course you have, present day you have many patients walking around with chemoports, lines, so many things. So just, it's very easy to identify. Generally the exterior or you can make out something which is sort of put in, and then it is going to be a possibility of lipomatous deposition. Of course you have to differentiate with other forms of thickness in other types of pathologies, but this is one in your checklist which you should think of. And usually the intraatrial septum has been compared to a dumbbell where you have the limbus, that is the extreme edges of the intraatrial septum, which can be thick, and then you have a very thin fossa orvalis. So could this be a lipomatous hypertrophy? That is what you need to be aware of. Now again, looking at fossa orvalis, so this is again, you can see how different it is from the limbus on either side. It's very thin and it keeps moving, fluttering. So this is one of the reasons why on the transthoracic echo, because it's in the far field, there's going to be a dropout, and it can mistake it for an ASD because of its thin nature of the structure. And you can have once in a while you can have the patent foramen ovale also. So your fossa orvalis is going to be, you have that thin area. And then The other variant which can be mistaken for pathology, so by itself it has some implications, clinical implications, but again you should be aware of the atrial septal aneurysm. So the atrial septal aneurysm, this is an exaggerated one, very gross, and it can be in milder forms also. So this can be on one side, it can be on either side, it can be mobile, it can have a lot of presentations also, and then you can see the one below where the color is, it can also be associated with patent foramen ovale. So if you do see it, your job is to see whether there is a patent foramen ovale, and if there is a clinical sort of a presentation associated, for example a stroke, so then you have to look a little more closely and see whether there is any thrombus associated with it, but otherwise you sort of just report it, it is there. And then you have the patent foramen ovale. Not easy to diagnose, so you have to sort of put on the color, and when in doubt you can always ask for a T, or you do even a contrast also. So this is a subcausal, so much better as far as identifying patent foramen ovale in the subcausal view. Then you have, this is the era of intervention, so you'll have these lot of devices which are being put in. So this is just a classic obvious example, but just to sort of drive home the message that you will be seeing a lot of devices which are there. Again, very easy to sort of know that the patient would definitely give a history, and then there will be a history of a procedure which has been done. Now the left atrium has been covered very nicely in the morning, so I'll just add a few things which could provide you more information. So one is that the ridge, which is also called as the Coumadin ridge. So this is a ridge which is always associated with the left atrial appendage, and then it is associated with the left superior vein. So the appendage and the left superior vein always go together, and the muscular fold which is there in between is the Coumadin ridge, and this can appear very prominent sometimes, and this can be mistaken for a thrombus. This is not seen so frequently in transthoracic, but you get to see it quite prominently in transesophageal echoes. So this is one example of how the Coumadin ridge can look very prominent here. So this the part above is the left atrial appendage, and just below that will be the left superior pulmonary vein. When you put on the color, you'll see a blue flow which is going down. Then, of course, far and few, so I'm more exposed to it, so that's why I'm presenting, but it's still part of the table which tells you that you should be aware of. So you have heart transplants, you have these suture lines, so I'm not focused much on it, unless those of you are working in a hospital where you have these patients, it's again easy to identify. Now let's look at the left ventricle. So left ventricle per se is not so tabaculated when compared to the right ventricle, but you do get some scenarios where the left ventricular apex can be quite tabaculated, showing increased tuberculation. And then again, you see that LV cord or the false tendon. So this again is seen in some patients, and this is how it looks. So your LV cord or false tendon which is there. So again, not much is associated, though there's some data associated with some arrhythmias, but that's a different area altogether. Just to sort of tell you that you have to look at the LV cord, and morning you've also been shown how to look at the muscle bundles, which are again going to be towards the apex. And this is how the LV apex looks like, and this is a problem sometimes when you have a very tabaculated apex and then you are suspecting a thrombus there, and the thrombus can mimic, and then you also have the apex very close to the probe, and then it can cause some artifacts. But you have to sort of you have the facility, you can always put in contrast, and you can try and differentiate what exactly that structure is. And just the last few slides. The other thing what you should be aware of is the epicardial fat, which is usually seen anteriorly, always most of the time associated with the right ventricular free wall and in the interventricular grooves. So it is more granular. So this is mistaken for many times pericardial effusion. So just keep this in mind. An isolated echolucency appearing anteriorly, very unlikely to be a pericardial effusion, so more likely to be epicardial fat. And then you also have the transverse sinus and echolucent area between the LA and the aorta. So before I finish, just one last slide, which a very sort of unusual presentation. Let's look at the aortic valve. I've not really covered the aortic valve. So this is a middle-aged female, rheumatic heart disease, MS, and came for a routine T for a PTMC evaluation. So if you look at the aortic valve, especially seen on transesophageal echoes, this is a structure which is called as the Lambel's excrescences, very exaggerated. It's almost like what you could call a giant sort of Lambel's excrescences. And this is usually seen at the coaptation area where the leaflets meet. So this is another anatomical variant which you should be aware of, and just the 3D showing where exactly that structure is coming. So you can see that it is coming at the edges, and it is flowing into the left ventricular outflow tract. And this is another example. So these are really prominent ones, obvious ones. So sometimes you see them very, very faint, but you definitely can pick it on TEs. And this is again the Lambel's excrescences. So just a brief definition. So it is described as a thin, filiform, undulating, can be multiple, appears it can be clustered also. It has got its own independent movement and it's hypermobile. So this is typical description. Of course, your differential diagnosis is always there for other causes, and it's always seen at the coapting area of the aortic leaflet. And literature says it's about 2 millimeters thick, and the length can be anywhere from 3 to 20. And what exactly one should do with this, if it is seen very obviously, is again in a clinical setting, is something which is another area. But you have to keep that in mind. And this is sourced from literature.